This schematic illustrates a clinical timeline that vestibular professionals know all too well. A complex patient makes steady progress through vestibular rehabilitation therapy, only to inexplicably hit a hard plateau where their recovery completely shatters. The conditions sitting at this plateau are functional and central balance disorders, specifically vestibular migraine, persistent postural perceptual dizziness, or PPPD, and mal de débarquement syndrome. These diagnoses consistently defy standard structural and habituation frameworks. In treating these complex cases, the standard error is to aggressively target the structural deficit while completely ignoring the patient's underlying biochemical baseline. This 3D model of the brainstem highlights the medial and lateral vestibular nuclei. Here, histamine operates as a central neurodestabilizer, directly altering their resting firing threshold. When systemic histamine increases, it forces these nuclei into severe hyperexcitability, drastically amplifying their electrical output. Faced with this erratic neural activity, our standard clinical reflex is to prescribe chronic H1 receptor antagonists, such as meclizine, to suppress the noise. This introduces a debilitating dual pathology. The systemic histamine overload locks the central nervous system out of normal sensory reweighting, while the chronic antihistamine use actively halts the process of central vestibular compensation. We need to track the exact biological pathway of this histamine cascade, examine why meclizine fails at the receptor level, and establish the biochemical stability required for recovery. You cannot effectively rehabilitate a central nervous system that remains under constant chemical assault. Biochemical stability must precede mechanical habituation. This microscopic footage visualizes widespread mast cell degranulation. This sudden release is the primary driver of systemic histamine accumulation, often triggered by chronic stress, systemic inflammation, or severe hormonal fluctuations. When a patient compounds those sudden biological triggers with a diet rich in high histamine foods, like aged cheeses, cured meats, and fermented beverages, the systemic chemical load becomes overwhelming. This split-screen logic model demonstrates the body's strict enzymatic pathways for clearing this burden. Diamine oxidase, or DAO, in the gut, and histamine N-methyltransferase, or HNMT, in the central nervous system, must process the heavy input. When these enzymes fail, systemic histamine levels skyrocket. Because of specific transport mechanisms, this systemic spike allows histamine to cross the blood-brain barrier and interact directly with the central nervous system. Once inside, the histamine molecules bind directly to specific receptors along the trigeminovascular complex. This binding forces the rapid release of calcitonin gene-related peptide, CGRP, and substance P, unleashing a localized inflammatory storm across the meninges and the brainstem. Within the vestibular nuclei, this resulting inflammation destroys the precise timing and symmetry required for stable spatial orientation. The patient physically registers this biochemical shift as spontaneous vertigo, intense photophobia, and extreme motion intolerance. Vestibular migraine is a state of profound neurogenic inflammation. Histamine serves as the primary architect of this physiological chaos. While neurogenic inflammation explains acute migraine attacks, this exact same chemical burden drives the persistent, daily unsteadiness seen in functional disorders like PPPD and MDDS. Because histamine acts as an excitatory neurotransmitter, it locks the central nervous system into a chronic state of sympathetic hyperarousal. This dual-screen visualization maps the core sensory conflict. On the left, visual and proprioceptive streams arrive cleanly. On the right, the hypervigilant brain receives an erratic, histamine-amplified signal from the inner ear. The datasets contradict each other entirely. Evaluating this severe sensory mismatch, the brain perceives an imminent fall. To protect the body, it abandons normal automatic postural control. This forces the patient to rapidly adapt a maladaptive sensory strategy. They become intensely reliant on either a strong visual or a strong somatosensory component to navigate their physical space. When a visually reliant patient encounters complex environmental stimuli, like the dense optic flow shown here, their primary coping strategy is completely overwhelmed. Because the histamine burden keeps the neural networks locked in an excitatory state, the brain lacks the flexibility to seamlessly reweight these overwhelming sensory inputs. Warning tone. Pushing a patient through complex habituation exercises during a severe histamine flare only reinforces this incorrect sensory strategy and provokes severe symptoms. The baseline histamine burden ensures that the sensory mismatch remains severe. Purely mechanical habituation therapies will remain ineffective until the internal chemical environment is neutralized. If histamine is the architect of the vestibular dysfunction, it raises a crucial question. Why do standard long-term antihistamines actively worsen functional recovery? H1 receptor antagonists do provide acute comfort. They artificially lower the firing rate of the hyperexcitable vestibular neurons, easing immediate dizziness. But central vestibular compensation is an active neuroplastic phenomenon. This diagram shows the postsynaptic H1 receptors located specifically within the medial vestibular nucleus. Successful neuroplasticity relies entirely on the baseline excitability of these exact receptors, which we see here actively driving the asymmetric activation of the commissural inhibitory system to rebalance bilateral vestibular inputs. When a patient relies on chronic antihistamines like meclizine, antagonist molecules physically cap and block these postsynaptic sites. The structural consequence is immediate. The active rebalancing halts, and the physiological error signals the brainstem requires to initiate synaptic remodeling go completely flat. Without those physiological error signals, the brain has no incentive to rebuild or rewire the damaged neural pathways. Extending suppressant therapy masks the underlying deficit, actively retards natural vestibular compensation, and delays the patient's functional rehabilitation indefinitely. True clinical success in managing chronic vestibular hypersensitivity requires looking beyond purely structural frameworks and addressing the physiological weight of a dysregulated histamine pathway. Returning to our clinical timeline chart, the immediate directive replaces standard suppressant pills with targeted dietary and DAO enzyme interventions. These lower the systemic inflammatory baseline. We see the hyperexcitable brainstem cooling back down to a calm baseline, changing the entire neural environment. Once the histamine cascade subsides and the vestibular nuclei return to a stable state, the nervous system is primed for new inputs. Introducing the Werner sensory integration method on our timeline reforms the shattered progress line, resuming its upward trajectory. Treating the chemical overload breaks the cycle of sensory mismatch, but systematic mechanical rehabilitation remains a strict requirement to rebuild the structural pathways. To implement this in practice, link this biochemical framework back to the Werner sensory integration method. This guide provides the clinical steps for transitioning stabilized patients into a progressive sensory reweighting program.